Hi, my name is Laura Liang, and I am here to discuss CAUTI prevention using evidence-based practice in hospital policies. Catheter-associated urinary tract infections, also called CAUTIs, account for the greatest number of reported healthcare-associated infections. This is something that is very dear to my heart because working in healthcare has opened my eyes to how prevalent this infection can be in our hospitals. Having personal experience in the hospital has shown me that catheter care is not being done as often. As a result, the patient receives a CAUTI due to our negligence of care. One time, I even had a patient go into septic shock after developing a catheter-associated urinary tract infection. Not only is this important to me, but it is also important to the public. It has been revealed that more than 30 million indwelling urinary catheters are inserted in the United States. Many of these have shown inappropriate and unjustifiable uses of these catheters because they did not follow the CDC requirements for catheter placement. It is also important to the healthcare system because in 2008, the Centers for Medicare and Medicaid Services, also called CMS, identified CAUTIs as being hospital-acquired. This means that it is up to the hospital to cover the related costs due to CAUTIs. A hospital with increasing CAUTI rates means that they can be penalized through a reduction in Medicare payments. CAUTI prevention is also extremely important for patients. The average cost to treat one CAUTI is estimated to be about $758, which is very expensive. Patient discomfort is also something that can happen as a symptom of CAUTIs. Patients can experience dysuria, frequent urination, abdominal, and flank pain. However, some patients may actually be asymptomatic because of the catheter's presence. There is also an increased mortality with CAUTIs, with about 13,000 CAUTI deaths happening annually. There is a longer length of stay associated with CAUTIs as well. Readmissions, morbidity, and mortality are also increased with CAUTIs. My PCOT statement for this assignment is, for nurses, does integrating evidence-based practice in catheter-acquired urinary tract infection prevention policies compared to current CAUTI prevention methods decrease the number of CAUTIs diagnosed in 1 year? I decided to compare evidence-based practice with current CAUTI prevention methods because there is not one single guideline that every hospital uses to help decrease the rate of CAUTIs. I also decided to use the timeline of 1 year because I felt like this was a sufficient amount of time to help see a reduction in CAUTI rates using evidence-based practice. The database that I used was called CINAHL Complete. This stood for Cumulative I have several different Index to rationale Nursing for selecting the and Allied articles Health that I Literature. did. The first article is The called search terms Targeting and Boolean operators that I Catheter-Associated also Urinary decided to Tract use Infections was in a Trauma CAUTI Population. prevention and The aim of this evidence-based article was to practice determine and whether the nursing. implemented measure would From reduce here, CAUTI I rates. yielded 115 The implemented different measure search that they results. used was called a CAUTI 5S This was still bundle. too much for me, so I The 5 decided to narrow S's it stood down for using a
staff,
few different stabilization, criteria.
support,
The first one I
spot,
used was
and
full
stop.
text because I wanted to make
For
sure
staff,
that I was
they
able
made
to
sure
read
that
all
there
of
was
my
enough
articles.
nursing education for cleaning
I also
the
wanted
Foley
my articles to
catheters.
be up to date.
For
So I
stabilization,
used
they
January
made sure
1st,
that bladder
2013
stabilization devices
to
were in place.
December 31st, 2018
For support,
as
education was
the criteria.
given to patients, families,
I
and
needed to make sure
caregivers
that
on
all of
catheter risks.
my articles were in English.
For spot,
And I also
the
wanted to
catheter
make
bag
sure
was
that
kept
it
below the
portrayed all
bladder
the
and
different
above the
age
floor.
groups.
For stop,
From here,
daily
I got a
evaluation
search
for
result of
discontinuing the
76
catheter
articles.
was needed. This article used a level 3 level of evidence. It was a well-designed quasi-experimental design, therefore I knew it was reliable. The second article I used was called CAUTI Prevention, Streaming Quality Care in a Progressive Care Unit. I really liked this article because it used a continuous quality improvement model to guide the study. The model used was called Six Sigma DMAIC, which stood for Define, Measure, Analyze, Improve, Control. This article discussed sustainable interventions used to decrease CAUTI rates. It used continuous education among the nurses about CAUTI prevention, and they also implemented their own CAUTI bundle. The third article that I used was called Catheter-Associated Urinary Tract Infections, Implementing a Protocol to Decrease Incidence in Oncology Populations. I wanted to use this article because I wanted to see how CAUTI prevention affected an already immunocompromised population. This one discussed interventions used to decrease CAUTIs as well. It also used a level 3 well-designed quasi-experimental design. Therefore, I also knew this one was reliable. The next article that I chose is called Implementing a CAUTI Prevention Program in an Acute Care Hospital Setting. This focused on enhancing hospital nurses' knowledge of indwelling urinary catheter care to prevent catheter-associated urinary tract infections among hospitalized patients. I really liked this one because it used different modes of data collection by using a pre- and post-survey design to examine the effects of the one-time CAUTI educational program for nurses. The last article that I chose is called Implementation of a Nurse-Driven CAUTI Prevention Algorithm. This focused heavily on the idea of empowering nurses to help decrease CAUTI rates. It used the Cantor's theory of organizational empowerment to help guide the study. It helped guide nurses by leading them to create the conditions for nurses' work by shaping the quality of support, information, resources available in work areas. When nurses perceive their leaders as authentic, open, and truthful and involve them in decision-making, nurses respond positively to their work and report higher work engagement and greater trust in management. This theory provided structure and, in nurses collaborated on the plans, became active participations in the execution of the algorithm and were responsible for the measured outcomes. While there were many similarities between all 5 articles, the overall one was that they all found reduction in CAUTI rates regardless of whatever evidence-based practice method they used. The execution of the 5S CAUTI bundle resulted in a significant 80% reduction in CAUTI rates. In another article, the CAUTI rates declined to 0 from 7.49 on one hospital unit and to 1.56 from 4.12 on a different hospital unit after implementing an educational program. On the progressive care unit, they achieved and sustained a CAUTI rate of 0 for 22 months with a 38% reduction of catheter days using a CQI model to guide their CAUTI prevention work group in designing educational classes. On another study, it showed that the evaluation of infections per 1,000 catheter days from 2014 from the third quarter of 2016 demonstrated a reduction in CAUTIs from 14.32 to 11.79. In the last article, it also showed that in May 2017, the CAUTI rate of 3.04 reflected a 36% change, which is significant and reflects an increased awareness of CAUTIs among the staff. While there were a lot of similarities between all of the articles, there were still a few inconsistencies. In one article, it stated that early results did not demonstrate a significant drop in CAUTI rates or indwelling urinary catheter days following the implementation of the protocol as expected. However, this could be due to the fact that there was an increase in surgeries for neurogenic and obstructive bladders during that initial time period. Overall, the evaluation of the infections per 1,000 catheter days still showed a reduction in CAUTIs from 14.32 to 11.79. The cost per CAUTI episode and the additional cost per years also varied between articles. In one article, it stated that the average cost to treat a single CAUTI estimated to be about $758, with an annual cost of over $340 billion in the United States. Another article stated that it estimated to cost $600 per CAUTI episode and $131 million each year to treat them. A different article stated that the average cost per CAUTI episode is between $1,200 and $2,700, and the annual cost being $400 to $500 million yearly in the United States. There were a couple gaps in the articles as well. In one article, it stated that the biggest gap was that hospital policies can be pretty inadequate and ambiguous. This can actually lead to inconsistent techniques, poor maintenance practices, missed provider orders, lack of provider awareness of the CAUTI risk, and inappropriate usage of urinary catheters. Another gap showed that nurses seemed to have limited knowledge of the current evidence-based practice with CAUTI reduction techniques. There were a few limitations as well within each article. The first article, called Implementation of a Nurse-Driven CAUTI Prevention Algorithm, showed that they were also limited by organizational policies that don't allow for implementation of these algorithms. The second article, called Catheter-Associated Urinary Tract Infections, Implementing a Protocol to Decrease Incidence in Oncology Populations, said that it was difficult to educate all providers about CAUTI prevention protocols and the lack of self-efficacy among oncology nurses. The third article, called Targeting Catheter-Associated Urinary Tract Infections in a Trauma Population, a 5S Bundle Prevention Approach, said that the study was only conducted at a single facility and it was difficult to study individual interventions separate from the 5S bundle. The fourth one, called CAUTI Prevention, Streaming Quality Care in a Progressive Care Unit, stated that long-term sustainability was its main limitation. It was really difficult for them to ensure that every float nurse on the project floor would be adherent to the study. And the last article, called Implementing a CAUTI Prevention Program in an Acute Care Hospital Setting, said that there was no reliable data that was available for the survey used to measure nurses' knowledge of appropriate indwelling urinary catheter care. In conclusion, there is evidence to support the use of evidence-based practice in hospital policies to help reduce CAUTI rates. One article stated there was an 80% CAUTI reduction rate using the 5S bundle. Another article stated that CAUTI rates declined from 7.49 to 0 and 4.12 to 1.56 per 1,000 catheter days in 2 hospital units using education programs. In another study, it said that they sustained 0 CAUTI days and a 38% reduction in catheter days. Another article also stated that CAUTI rates declined from 14.32 to 11.79 per 1,000 catheter days as well. And the last article said that they reduced their CAUTIs with 30%. While there is no specific guideline in place, there is a lot of evidence to support this practice change. Ferguson states that CAUTI rates declined in both the neurotrauma ICU and telemetry units in the quarter following the education program, and this finding is consistent with the evidence-based literature and demonstrated that a multifaceted CAUTI prevention program can help reduce these rates. Thank you for listening to my literature review assignment. I hope this gives you a better understanding about how to reduce CAUTI rates, and I hope we can solidify one specific hospital policy for everyone to use based on evidence-based practice.